Hello, Dr. Rondeau. I'm a neuropediatrician. I work in the teaching hospital in Rouen, in the ward where we look after babies between the ages of 0 and 3 years who suffer from neurodevelopmental disorders. And I've been asked to talk about epilepsy and neurodevelopmental disorders, especially within the framework of MIT1L syndrome. So neurodevelopment disorders are something that you probably heard about a lot. I have looked at the classification with DSM-5. DSM-5 being one of the classifications. There's also STIM-11. They try to classify the disorders that appear during the period when children are developing and which have an impact on brain development and the different stages, normal stages in the neurodevelopment, knowledge acquisition, skills acquisition, and this has an impact on the future of the child. These disorders can be observed very early on in life, and in the general population, depending on the studies, we talk about 10 to 15% of the children being affected versus the population at large. So it is quite a big percentage. The origin is multifactorial. There is a genetic origin, but there is also an environmental origin. And when I talk about the environment, I don't simply mean exposure to toxic compounds, but it's also the family, the environment in which the child lives. And there may be something inherited, not necessarily a genetic abnormality, but something inherited from the parents. There may be siblings, aunts, or parents who already suffered from neurodevelopmental disorders, and that means a greater risk for the offspring or the next generation. And the cause is not really as well established as what the geneticists would do with genes. Maybe there are several genes working together to lead towards disorders, or maybe it's a combination between genes and the environment. All these disorders are very often not standalone disorders. They are combined. In some children, the disorders are well identified. In other cases, there are so many disorders combined that it's not very a clear picture. When we talk about motor disorders, we talk about dyspraxia, coordination disorders. In acquiring coordination, the child has trouble planning emotion and executing it in a quick way. When we talk about communication disorders, it means that there is delay in speech and oral communication. It used to be called dysphagia. There is also stuttering or disorders in social communication, and there are also learning-specific disorders such as retardation when learning to read and write and spell and make calculations. There are also autism spectrum disorders, and finally there are intellectual development disorders. It's a synonym of mental retardation. All these disorders can be combined with each other in a more or less marked way, but they're very, very rarely standalone. I'd like to show you a slide on attention deficit disorders, and then autism syndrome disorders and intellectual development disorders. According to the classification, I would like to tell you what the criteria are and explain why it's very important that we identify the signals. Now, it's not so much finding a name for every problem that matters. It's really spotting the issues and understanding the consequences of those issues and what we can do to mitigate the consequences. According to DSM-5, DSM-5 being the classification, official in a way, according to the American Psychiatric Association, the criteria were published in 2013, and they refer to attention deficit, isolated lack of attention, associated with hyperactivity or a very impulsive behavior, and that leads to what we call ADHD. And I try to simplify, but I wrote a box with a definition. It really describes what can be observed in children or adults suffering from attention deficit disorders. People have trouble paying attention to a detail or having a sustained level of attention during a long period when playing, children who have trouble listening for a while, people who have trouble applying instructions, focusing on daily work or activities, trying to avoid all the tasks that would require a sustained effort, people who lose their misplace or lose their objects or forget things very often. So when you see any or all of these signs, you should always think that those are attention deficit disorder symptoms. But at least these symptoms should be present in two different environments, both in school and at home. And the consequence should be a significant alteration of the way the child or the adult functions, both in the school, in the workplace, or at home. And this should have an impact on the quality of life, and it should not be accounted for by another kind of mental disorder. Say the patient has depression. Obviously, depression will have an impact on the daily capacity to focus on a given task. So we have to make sure that there is no other problem involved. Attention deficit can be specifically related to neurodevelopmental retardation when there is no other cause for the symptoms. And regarding hyperactivity and impulsive behavior, people who are fidgety on their chair, get up and sit down again. When they're in the classroom, they will get up, or when they're at home, they will also be fidgety, will never stay in the same place when doing leisure activities or when working. People who speak too easily, answer the question before the question has actually been asked, who have trouble waiting for their turn to speak and will interrupt other people speaking. That is also the picture that we're looking for. For attention deficit criteria and hyperactivity criteria, we need to have at least 6 symptoms, and they should be present at least for 6 months. It shouldn't be a transient phenomenon that you have observed for a few weeks. It should be something that is lasting in time. And it's worth mentioning also that the degree at which the disorder is observed, both for attention deficit or hyperactivity, should not match the child's developmental level. It should be more marked than what could have been expected for a child or an adult of that age at a given. For instance, a child with a developmental deficit disorder should have a lower developmental level. And if some disorders are obvious for attention deficit or hyperactivity or impulsive behavior, if they are more severe than what could be expected for somebody at that level of developmental disorder, developmental retardation, we can say that we have an issue here. So it's not just a child with developmental retardation with a certain level of symptoms that could be expected, but a symptom that doesn't match the level. And we can maybe act with drugs or intervention on a child that has developmental disorders. It wouldn't be stupid to suggest help to mitigate attention deficit disorders when there is more at play than just an attention deficit. Autism spectrum disorders. Again, according to DSM-5, we talk about the autistic dyad, no longer triad, but dyad. There is a combination between communication deficits and deficit in social interactions, combined with a restrictive and repetitive trait in behavior and interest. So again, here we have a wide spectrum that covers a number of situations that may vary from one patient to another, but in summary, it's difficulty of having a reciprocal behavior with regard to emotions, social interaction, non-verbal communication, verbal communication, but also non-verbal communication. difficulties in starting an interaction, upholding the interaction, and having a very precise understanding of the interaction, and also the level of interest. There may be repeated behavior, gestures or words being repeated, or difficulty accepting change, or difficulty being flexible in one's daily routine. And some children really have very limited interests, sources of interest, or atypical ones for their age or their social environment. And very often we observe excessive or lack of emotion or sensitivity to sensory stimuli, because the difficulty to respond or accept emotions, sensory signals in a peaceful way, in a consistent way, leads the children with this kind of autism spectrum disorders to have difficulties in understanding and having outbursts in their daily life. The symptoms should be present from the very early stages of development. Very often they can be observed before the age of 3. Sometimes they appear during the first year of age. Very unspecific signs such as hypotonia, atypical motor capacity, a strange way of walking or turning around. And also there are interaction disorders that will take precedence over the other issues. Sometimes the children seem to be developing normally the first year, and then in the following year they seem to go back with regard to their communication and integration capacities. And these disorders should have a significant impact on the school life, the professional life, or the family life of the patients. Something else worth mentioning when we talk about the autism spectrum disorders, communication and social interaction disorders should be higher than what could have been expected with regard to that person's developmental retardation. Somebody with a developmental retardation has lower communication capacities versus somebody who doesn't suffer from this kind of retardation. However, before we can talk about autism spectrum disorders, we have to observe that the capacity to interact socially is really hindered. It becomes the person's weakness, the major weakness in the developmental process. Now, about intellectual deficiencies or intellectual development retardation. This is a definition based on 2 pillars: the objective measurement of the intellectual quotient with scales such as Wechsler's or WPPSE or WISC. These scales will provide an objective measurement, a measurement that tries to measure the person's cognitive capacity with tools so that the person can be classified versus the average score obtained by the population in general. When we measure the intellectual capacity with this kind of tool, we can classify the subject on a Gaussian curve that looks like a bell. The majority of people will be within the bell, but a few outliers will be either above or below. A few will be above and many will be below average. And the code, though the consensus consists in saying that people with an IQ lower than 70, that's 2.5% of the population, and with those people we can say that they suffer from intellectual deficit. And I'd like to talk about the little red curve. And there is another group, part in the definition, referring to people who not only have a low IQ score, intellectual functioning scores that are below average, but also people who have trouble adjusting people who have trouble managing practical things in daily life. And here the scale is more a questionnaire regarding all activities in daily life, how the person adjusts, how the person can interact with other people the same age or in the same environment, how the person will take care of herself or himself or take care of his or her house, and will be able to move around and maybe perform more finer motor tasks, how the person can communicate with speech, written language. And in theory, in order to be able to establish the diagnosis of an intellectual deficiency, the two should be combined.
And so this red curve that I've added, same shape roughly as the IQ curve for the general population, but in genetic disorders where there's impairment of the cognitive system, we have that same curve that slides slightly towards the left. And a part of the population who have this genetic disorder are below the score, the IQ score, and not everybody has the same IQ, not everybody has the same capacity. Some people have a lot more difficulty in the lowest levels of the curve, and others better levels on the right-hand side of the curve. And so if you put the graph presented like this, then some people will be classed as having a deficiency and others not. So you can imagine that for this MEAT1L syndrome, it doesn't mean that because they all have this MEAT1L gene producing this protein or not, that they have the same IQ. There are differences. Everybody has their own profile, if you will. So if we take this definition of intellectual deficiency, that's the official one, then what's important, we can see, is to work on adaptability, flexibility, adapting to your environment every day to try and become more and more independent and to allow people to be able to live their lives independently. And here, I thought it was useful to just talk about this again. We talk about diagnosis a lot and the etiological diagnosis, the common cause. But with patients who all have the same cause, the same gene anomaly, there are not always the same expressions. Some children, some adults will have autism, others will have mental retardation, some will have problems on the coordination side. So that's what we call nosological diagnosis, but there's also the functional diagnosis. So with all of this, how does the person behave? How do they deal with the symptoms? Which ones do they find really inhibit them, or others who maybe they find helpful? How does that person interact with others? How are they able to communicate? All of this, I think, is more important. What are the symptoms? And what are the advantages and disadvantages, weak points and strong points, and how can we use the weak points and try and improve them and use the strong points to try and make them feel better? And we're talking about diagnosis and handicap, and according to the WHO, the classification of function and handicap, the definition of being disabled is a restriction to be able to access activities that others can access, people around you in society. And people are considered disabled when they cannot access things that they normally would be able to access in society. So it's not just to do with their health or organ dysfunction or intellectual deficiency. It's also about how society adapts to that person and integrates them into society. That conditions their handicap. And I think it's very important to provide support very early on. Professor Marin, who works at the hospital, is a strong proponent of this. When dealing with neurodevelopmental disorders, we know that when we are very young children, we acquire capacities to do things, and those things that we're able to do become more and more complex as time goes by. So dealing with this and providing the support as early as possible means that for each step of the way, the help will be there to balance that child's development out. So giving them tools, giving them physio, helping them right from the beginning to acquire the capacities they need to then go on to live a normal life. And I'm sure you're familiar with this idea of cerebral plasticity. The first 3 years of life, in fact, is when the brain is really still very supple and plastic, and those connections are only made over time in the brain, and so we can influence them. And we can correct some of the connections that are made that are causing problems. Right from an early age, we know that we can modify the brain more easily, but that doesn't mean we have to interrupt its evolution later on. So this is just to illustrate developmental trajectories. When we assess somebody's development, it's at a given time, and it doesn't give a global view of their development. It's just about answering the tests, responding to the tests at that given time. And all kinds of things kind of impacted that. Were they really ready for the tests? Were they comfortable? That's not how we should test them, or perhaps that's not how we should assess them. We should maybe think about how quickly they acquire capacities, learn things, or maybe if they manage, thanks to physio or various other therapies, to improve things, and how quickly they can do that. If it's slightly slower than other children of the same age, then maybe that's something to look out for. You know, some parents of children that are mentally retarded ask us whether their children are going to catch the others up. And we can see that with time, to match the normal development curve, you would have to be developing quicker than the other children. So every step forward, every bit of progress is great, but the aim, trying to recoup or to achieve the similar level of development as other children, is still very, very difficult. Now, what's important, and the things where we can have an impact, is what we call the kind of extra handicaps. We can try and impact those, make sure that that person doesn't do even worse than its potential. We need to focus on that. That would really stop the child and then the adult of reaching their full potential. I know you're familiar with this, but anything to do with the sensory side of things as well, hearing, vision, we need to really make sure that there are no problems there, correct their vision if necessary, do an orthoptic assessment as well to see whether they may need some help there to correct any visual impairment. But hearing as well should be monitored, and maybe if they're having ear infections, then recurrent ear infections, that's something that could be also impairing their hearing. All of these things, you know, maybe sleep apnea, snoring if a child is very tired first thing in the morning, or sweating a lot during the night. Maybe they need to do tests to see whether they do have issues. We need to treat and recognize epilepsy if they have it, because repeated epileptic seizures has an impact on development. We need to tackle weight problems, we've talked about that, attention deficits, that can be dealt with. We know how to deal with those, we're quite good at dealing with those, but also using drugs perhaps as well, managing frustration and managing emotions. These are all very important. And now I want to talk about epilepsy a little bit. It's not always easy when we talk about epilepsy or seizures, convulsive seizures, to know exactly what it is. So an epileptic seizure or convulsive seizure is when there are signs that show an excessive behavior of the brain's neurons. Here is an example with somebody who has is having an epileptic seizure. So suddenly we can see the brain's electric activity using the ECG, and we can see that suddenly all of the electric activity throughout the brain is behaving very abnormally with lots of peaks and troughs for roughly 15 seconds. And then it kind of goes back to normal. This is what we call one of those absent epileptic seizures. And it is an example of how the brain functions on an electric level when you have this kind of epileptic fit. And we talk about epilepsy. When we talk about epilepsy, you have recurrent fits. So you have this disease when you've had at least 2 fits that are unprovoked, because it can be provoked or triggered by hypoglycemia, by fever, by a knock to the head, and 2 fits within 24 hours we consider is somebody who is beginning the disease. Or you can see one first initial fit, and on the ECG we can tell that it's a child who is probably going to have more seizures. Or if we can see a very early onset epilepsy, then we can also tell from that various other things. And these ECG abnormalities, when they are not associated with epilepsy, I mean, can happen quite regularly. You know, when people have neurodevelopmental disorder, but if they do have clinical epilepsy, if they don't have clinical epilepsy, then you shouldn't treat it as you would epilepsy. It just means that they have cerebral development that's not exactly like everybody else, but you shouldn't necessarily then embark on anti-epileptic treatment, because you might be adding to the problems. So, given the data that we have from the studies run by Dr. Kursimova from 2023 plus the patients that she took on, that equated to 62 patients. 17 of those had epilepsy, so that is 27%. And on their intellectual capacity, only one patient out of 13 had no mental retardation. So you may think that having epilepsy equates to a higher risk of intellectual deficiency, but it's not the case. We only have very few little data to base this on. We can see that the average age where children learn to walk with epilepsy is later, 28 months, whereas the average for the cohort was 24. But this morning you said 22 months, so maybe it is 22. But there was a difference there. And according to the type of mutation, is it a missense or not, or truncated? I don't get the impression that there was a specific kind of epilepsy linked to that. And the types of epilepsy were variable. There were myoclonic fits, there were absent epilepsy, there were generalized tonic-clonic seizures or hypothermic seizures in children. And you might even wonder whether that is in fact epilepsy. Sometimes these children don't get offered any treatment and the fits stop when they reach 5 or 6 years old. Variable severity, some had no recurrence, some had the epilepsy was kept under control with just one kind of treatment, one drug. A small number of patients had a more severe epilepsy that needed stronger treatment. So there's no one single type of epilepsy. I just wanted to show you a few examples of epilepsy so that it would be a little bit more visual. So this epilepsy, absent epilepsy. Okay. So absence epilepsy, that's an epilepsy that can appear spectacular. So somebody will suddenly stop doing what they're doing and they will seem visually to be absent. They don't necessarily fall over. They may just kind of twitch a bit, and that can last. It comes on very suddenly. It can last a few seconds or dozens of seconds, but no more. And it can be very frequent. Some children do this dozens of times a day, and that really does have an impact on their capacity to focus, to concentrate, to remember things, and to learn. Let me just show you the video. So we're getting this child to blow on a windmill because when you get the child to hyperventilate, that often triggers an epileptic fit. And suddenly you can see he stops, then he's blowing a bit more. And then you see he stops completely, and then you could talk to him or touch him, pinch him, no reaction. Automatic movement of the arm. And then you'll see that he's just back and it's finished. And you may not even notice it, actually, sometimes. If you're in the room next door, you come back a minute later, you won't have noticed it. So you really need to be able to tell the difference between a daydreamer, if you like, and somebody who's having an epileptic fit. If you touch them and they come straight back to you, then they're probably just daydreaming, but otherwise they might be having an epileptic fit. Now, these are have more movement. This is the same child. You can see there is trembling and twitching of arms, legs, loss of contact, and then back. And I want to show you one last video, more kind of classic epilepsy, or what people expect to see, the tonic-clonic seizures. And that's a sudden loss of contact and rigidity in the body all over. And then these kind of shaking or twitching, clonic twitching that we call, and that can last for a while. Now this was filmed in the dark. A child who suddenly goes rigid a bit and stiff. You can see the feet are twitching a bit here, they're stiff, and then the shaking. Still in his seizure, and he's absent. This child is absent visually, can't see at the moment. He's unconscious. And then suddenly it stops, and there's a post-acute or post-critical phase where the child is just very tired, a little bit lost, tired, just floppy. No, the seizure isn't over yet. Okay, and then it ends. So I've shown you these videos because I want to kind of demystify epileptic seizures, and I want parents to be able to recognize what they look like in case it happens. So my main message is to try and provide the child with regular support in a kind of framework that suits the child. I mean, it can be more or less. You can't try and remedy everything at the same time. I mean, you need to give the child some freedom. They need time to play. They need time to be bored. You can't just constantly be doing treatment and physio or whatever. So that can be hard to find the right rhythm. You always need to work in the proximal development zone. So push them a little bit, but not too much. The child should be able to achieve that objective. It must feel like it's just above what they can already do. You also need to take into account the inter-individual variations within the disorder. Not everybody has the same problems or the same level of disorder, and you need to do a functional diagnosis. What is the child able to do on a day-to-day basis? What are their strong points, their weak points? Make it very concrete, because that helps the doctors give you better advice and better care. Be very specific. And the final objective, of course, for parents and doctors and all of the health professionals is to enable that child to become independent and a happy, fulfilled adult. And you're not treating somebody with an ECG, but you are dealing with somebody who has epilepsy. So you really need to see them as a person. Okay? And I think that everybody agrees with this. Medicine is a hatred for disease, but a love for the patient. Thank you.